This presentation is an example of Case of the Week, prepared and presented by birdultrasound.com.au. Please visit birdultrasound.com.au where you'll find many more Case of the Weeks as well as a wide range of other ultrasound educational material to enjoy. Welcome to Case of the Week. This week's case is on carotid ultrasound, and I'm going to present a case where we found some significant plaque in the bulb area of a carotid ultrasound in a young patient, and how we go about dealing with this, quantifying it, reporting it, and how it can change the patient's management. We know that with the carotid bulb, you can see that the common carotid artery widens slightly just prior to the bifurcation, and then as we have the origin of the internal carotid artery, it's also slightly widened through this area here. So this is known as the carotid bulb, and it's a really common location to see early soft plaque development, intimal thickening, etc. So in this patient here, you can see that there's really minimal plaque starting to form. At this level here, we've got normal intima, but as we head sort of into the area of the bulb and the origin of the ICA, you can see you've got this slight thickening here, a little bit of early soft plaque formation, and this is really, really common. So this is not going to be a hemodynamically significant lesion. In fact, the flow velocities through here and the laminar flow is really undisturbed by this very, very minimal amount of plaque that's forming here. So how do we deal with this? How do we quantitate it, and what do we think of it? Well, if I saw this type of appearance in a 60-year-old patient or a 70-year-old patient, I'd really congratulate them and say that they've got less plaque than I expect at their age. So their vessels are in very good health, and they're clearly not going to be an arteriopathic patient. But if I see this appearance in a 25-year-old or even a 30-year-old, I might then start to question whether or not their vascular health is as good as it needs to be. Because this bit of early plaque formation might be the tip of the iceberg. It might be a first indication that we have an arteriopathic patient. And if we think about the work that was done with intima media thicknesses, this was really, if you like, along the same lines of thinking. So in this case here, what I would say is that there is a minimal amount of soft plaque formation in the carotid bulb and the ICA origin, and I would just look at this and say that it's in the order of about 10% diameter reduction as a maximum, so really not much at all. We have a bit of a problem with the way that Nascar deals with these type of stenosis. And so Nascar is the North American Symptomatic Carotid Endarterectomy Trial, and it was an angiography study that really determined that once you have a carotid stenosis, it was worth going on to do an endarterectomy or at least come up with some management plan to help prevent strokes in these patients. Now, because it was angiography based, it really finds itself unable to deal with the concept of plaque burden. Now, what I mean by plaque burden is like that last patient where you have plaque forming in the carotid bulb area at the origin of the ICA, so this area here. Now, the way that Nascar works, because it is an angiography study, is it looks at the diameter of the more distal ICA, and then it compares that diameter with the area where we typically see plaque in the ICA, which is this area here in the bulb area. Now, if the diameter of A is the same as the diameter of B, it calls this a 0% diameter reduction. So it says there's no plaque, this is a normal patient. What we know, however, with ultrasound is that the bulb is much wider here, so the vessel is much wider than the distal ICA. So while you can have a situation where diameter A and diameter B, for argument's sake, are identical, so they're exactly the same, we know when we do an ultrasound that when we see that being the case, we may have a significant buildup of soft plaque here that goes unvisualized and unreported on the angiography, but is very obvious on the ultrasound. And this can really change the way that we think about the patient and their management. So the case I'm going to show you is a case of exactly this type of phenomenon going on. This beautiful diagram here was made by the wonderful Martin Neckes, who is an absolute star when it comes to all things ultrasound, and he's very, very good at making schematics. You can see this quite beautiful diagram. So here we have our common carotid artery, the external carotid, and the internal carotid artery, and here's the anatomical bulb area. And what we can see here is this yellow area here is a bit of plaque that's forming in the bulb. So this is a bit of plaque burden, if you like. It's soft plaque filling the bulb, but you can see that the diameter here of the distal more distal ICA and the diameter here are identical. So in terms of Nascet's angiographic assessment, there's nothing to see here. This is a 0% diameter reduction. But what we can see on the ultrasound, however, is we can see the significant soft plaque. So it might be 10%, might be 30%, might be 30 to 50%. We need to sort of somehow come up with a way of quantifying this amount of plaque and putting it into the report, because if this is a young patient, it may be that we've actually now diagnosed this person as being arteriopathic. It's really important to understand the difference between diameter reduction and area reduction, because mathematically they're very, very different things. So if we're going to play this game of putting an ellipse around the vessel, around the ICA or the bulb, wherever the plaque is, the outside lumen, and then put another ellipse or a spline trace, etc., around the patent lumen, and then work out the difference between this area and this area, this is going to give us an area reduction. So if you take this one, for example, if we did that trick where we put calipers around the outside and then calipers around the patent lumen, it might give us a 75% area reduction. It's really important not to put that number on your worksheet and have that number reported, because the reporting that we do with carotid stenoses, as we do with all stenosis in the arterial system, is we work in terms of diameter reduction. So you can't do this trick and report the number mathematically that you arrive at. You then need to convert your area reduction to a diameter reduction, and you can see when you do that, it makes a massive difference. It takes it from 75% area reduction back to 50% diameter reduction. So if you look at these numbers here, an area reduction of 44% only equates to a 25% diameter reduction. 75 area becomes 50 diameter. 94 area becomes only 75 diameter, but 99% area does become 90% diameter reduction, and it's diameter reduction that we need to report. So this is a case that I scanned this week, and this gentleman is young. He's in his he was 44 years old, and you can tell by looking at the neck musculature and the adiposity here, he was fit. So we've got a fit, healthy 44-year-old male, and he presents to me with a TIA, and the TIA was some slurred speech that persisted for several hours and then spontaneously resolved. And he's had a normal CT of his brain. So he comes to me for a carotid ultrasound, and I can only assume that he's going to have an echocardiogram of his heart done as well. And when I put the transducer on, I was quite taken back as to how much plaque burden he has in the carotid bulb. There's a significant amount of soft plaque on both sides of the carotid bulb. And of course, you can see, though, that the residual diameter here, like if we did an angiogram and use the Nascar formula, this diameter between here and here is still going to be larger, in fact, than the diameter here of the more distal ICA. So in terms of Nascar, he gets a 0%, nothing to see, which is fine, but in terms of the ultrasound, he has significant soft plaque burden, and at the age of 44, I would suggest that this is more soft plaque than you would expect to see, and I think this gentleman is going to need to have his be checked for his typical risk factors. He was a non-smoker, non-diabetic, but clearly he must have some lipid imbalance or some other issue going on that's depositing this soft plaque. So here it is in transverse, and you can see that the degree of soft plaque in the bulb, just as we come to the bifurcation there, you can see there's a significant amount of soft plaque. I'm using the sternocleidomastoid muscle there as a beautiful acoustic window, and so we're getting a really nice look at the soft plaque, and I've got my machine optimized to make sure that I can see that soft plaque and we're not turning it black and having it disappear on us. So that's the short axis view, and you can see how much plaque there is. When we put the color Doppler on, you can see that it's really not flow limiting at all. So the flow remains laminar, there's no turbulence, there's no acceleration of the velocities through here. So in terms of the pulse Doppler assessment and color Doppler assessment, it was entirely normal. However, with the color Doppler, you can really appreciate how much soft plaque there is sitting in that bulb area. It's quite important with these cases that you optimize your color Doppler really nicely. You can see I've got my pulse repetition frequency set at 38.4 here, and you make sure that your color right priority filter is not set too high so that you're not overwriting the soft plaque with your color information, and make sure that your gain levels are just right so that, again, you're not getting bleeding of this color Doppler over the soft plaque and making it disappear artifactually. So it's a real balancing act when you're dealing with soft plaque to make sure that you've got your pulse Doppler and your color Doppler optimized just perfectly. Also, in this case here, you can see that there's no evidence of any ulceration. So plaque ulceration is a real risk when you're seeing soft plaque, and you can see here there's no ulceration. It's a beautiful smooth plaque with a nice fibrous cap, thankfully, at this stage. So I really don't like doing this. This is against my DNA to want to do an area reduction on a carotid plaque like this. But in this case, I didn't feel like I could just sort of pluck a number out of the air. I know this is a significant amount of plaque for a 44-year-old male, and I know it's going to make a difference to the management. So I really wanted to give my radiologist a number to report that was as accurate as I could manage. So what I've done first is I've done a simple ellipse diameter around the bulb area here where the plaque is, and I've asked it to calculate an area that we've got there, and it's given me 0.91 square centimeters as the area. The next thing that I've done, and you can see that the patent lumen on the inside of that is quite irregular, so I can't use an ellipse. I need to use something different, and thankfully this machine has what is known as a spline trace. Otherwise you can try a continuous trace and hope that you're nice and steady and you can get that right. But the spline trace is a beautiful tool for this, and what I've done then is I've traced around the patent lumen. I had a look at it with the color Doppler, but then in this case I felt like I can really see the soft plaque beautifully on this machine using that sternocleidomastoid window. So I've now spline traced around the patent lumen, and this has given me an area of 0.41 square centimeters. So now I've got two numbers, two areas to work with. I can then mathematically divide the 0.41 by the 0.91, and that gives me 0.45. I can then multiply that by 100, and that tells me that I've got a 45% area reduction. So what I need to do then is calculate what a 45% area reduction means in terms of diameter reduction, and 45% area equates to approximately 25% diameter reduction, and that's the number that I can put in the report. And so I'm saying that this gentleman at 44 has a 25% diameter reduction. Now, that doesn't sound like a lot. You know, you don't get hemodynamic changes until you get to 50%, but at the age of 44, I think this soft plaque is excessive for age, and this gentleman will have his blood pressure and his lipids, etc., assessed, and he may have some other imaging. Perhaps he might even score himself a CT of his coronary arteries just to see what's going on there as a baseline as well. So it will certainly change the management for this gentleman, and I think this really highlights how we can look at plaque burden, and it's not all about just high-grade stenoses with high velocities, etc. When you get significant soft plaque forming in the bulb, then it's worth reporting. Age match it for your patient. So clearly, if this gentleman was 80 years old, I wouldn't have been concerned, but at the age of 44, I think it's worth reporting, and adds another string to the bow of how we manage our patients in the vascular world of ultrasound. I hope you've enjoyed this Case of the Week example by Bird Ultrasound. Please stay in touch with me at this email address, stayintouch@birdultrasound.com.au, where you can ask me any questions you like about this presentation, and also any questions about any other ultrasound-related matters. And please be sure to visit birdultrasound.com.au, where you can subscribe to the website and enjoy many more Case of the Week examples, as well as a wide range of ultrasound educational material covering a really diverse range of topics. Happy scanning, and bye for now.